We're just waiting for our fellow colleagues to just join, and then we can start. So we are just giving them at least 2 minutes, and then we can start. All right. Good evening, everyone. Am I clear? Is my sound okay?
Yes, it is.
Okay. So today, our speaker, a little bit about our speaker. His name is Dr. Colin Madede, and he's going to be presenting on the STEM technique for posterior composite restorations. So a little bit about our speaker is Dr. Colin Madede, holder of a Bachelor of Dental Surgery at the University of Zimbabwe, and has a year of general dental practice. And he is a past president of the Zimbabwe Dental Student Association, ZiDA, and has won the overall best student at the University of Zimbabwe, best dental student at the University of Zimbabwe. So Dr. Colin is passionate about restorative and conservative dentistry and is planning on further developing his knowledge and skills in these respective fields. He's also passionate about outreach programs and has undertaken several of them since he was a student. So with that, Dr. Colin Madede, over to you.
Thank you, Dr. Chatima. Good evening, ladies and gentlemen, fellow colleagues. So today I'm going to present on the STEM technique for posterior composite restorations. Right, so a bit of a background on the STEM technique. So the STEM technique really is still a novel technique, and it was developed by a group of people who were led by Mirahin. Their focus mainly was on the development and reproduction, rather, of the occlusal topography, the original occlusal topography, during composite restorative procedures. His main area, Mirahin, was on biomimicry. So he argued that the best occlusal topography is the patient's best. So we have a textbook, occlusal anatomy, but he was arguing that if we can try to replicate the original, the patient's peculiar original topography, then it is the best. So the three main issues he was dealing with was time, the anatomy, and the function, right? So if we are to compare the traditional versus this novel STEM technique, the traditional composite restoration being the direct, and then the STEM technique can actually be considered as an indirect method, because we are fabricating a negative imprint of the original tooth structure prior to cavity preparation. So it's really the matter of trying to make sure that at the end of the restoration, we have the architecture that is as close as is possible to the original topography. So this technique is utilized for pit and fissure caries, class 1 and class 2 caries. The direct restorations, however, are indisposable because they actually can be used for all types of composite restorations. Right, so good knowledge of dental anatomy is still of the utmost importance to the dental practitioner. So by any means, this new novel technique going to replace that. So we still need our skills, we still need our knowledge of carving the final restoration that will mimic as closely as possible the original tooth structure of the patient. But this indirect STEM technique gives the dentist a time-effective solution of dealing with these anatomical precision techniques. So according to Murashkin, 2017, that was his thesis. So we have to understand first the rationale of using the STEM technique. So one, you want to be using it on posterior teeth, evident, which are evident, caries which are evident on the posterior tip during clinical examination. But as I have indicated, you must have intact marginal ridges. So by intact marginal ridges, we are saying we do not want a tooth to be working with this technique. We don't want a tooth that is obviously cavitated. So if we have probably some pit and fissure caries, where even on the radiograph it shows that there are still caries under and inside the tooth, then that's a good case to work on. So the second rationale, we want to achieve accurate occlusal topography. So this is the most important aspect. We want to have this biomimicry of establishing an accurate occlusal topography. So restoring the original anatomy of the tooth, right? Then balanced occlusion. The issue of balanced occlusion is defined by Davis et al. It's the simultaneous bilateral contacting of the maxillary and mandibular tip, both in anterior and posterior occlusal areas, in centric and eccentric positions. So there is a role of restorative dentistry in occlusion, a major role. Right, so as outlined in this Wheeler's text image, we see that there is a coincidence on occlusion, which we must always try to maintain. So we want to make sure that when we restore a tooth, why should we really mimic the grooves and the ridges, and just to make sure that we have this good intercuspation, what we call the maximum intercuspation. We are not aiming to just drill so that the patient is comfortable, but no, we want to make sure that there is this coincidence. So coincidence of maxillary lingual occlusal line and mandibular central fossa line, then coincidence of mandibular facial occlusal line and maxillary central fossa line. So really, we have that in mind when we are doing our final composite adjustments. And then, of course, just to highlight on the problems to do with high restorations. These are some of the problems. We have to make sure that we do not have the high restorations. Issues to do with toothache, tooth tendon biting, tooth wear, spastic masticatory muscles, muscle tension headache, condyle disc displacement, and the degenerative arthritic changes in the TMJ. So this is just a reminder of why we should really focus on that final part of the restoration. Right, then there is the issue of the articulating paper. So there is still from arguments that should we stop adjusting after the patient is okay with it, or we should really make sure that there is no areas that are marked on the articulating or on the tip from the articulating paper. So we have to still remind ourselves that the blue strip is used for the side to side. When we ask the patient to slide side to side, so this is for patient's dynamic occlusion. Then the red strip is used when you ask your patient to tap. So that's for the patient's static occlusion. So we just have to remind ourselves. Right, so without further ado, we will dive into the stem technique. It's also called the Moose technique. And also one of the gentlemen who developed it was Maroon Motawi. So I've had the privilege of having a patient who came in so that I could actually experience it myself and work on it. And it was amazing. And I have prepared several pictures as that are going to show how we are actually going to be utilizing this. So this is not really theoretical, it's actually a practical procedure. So I had a 23-year-old gentleman who reported to the dental clinic with complaints of black stains on his left posterior tooth region. There was no relevant medical history, and the dental examination was conducted. The patient had good oral hygiene with pit and fissure caries noted on 3-6 tooth. The marginal ridge was not involved, which was good for my case. And then I took an intraoral radiograph just to ascertain the extent of the caries. Then I decided to employ the novel stem technique using the composite resin. Good. Right. So this is how the tooth was looking. So initially, this is how it was looking. You're noticing these pit and fissure caries. You have to forgive me, I actually forgot to include the radiograph. So on the radiograph, you could actually notice the caries undermining, but this is how it was looking clinically. So no obvious cavity, we need an intact marginal ridge. This is the occlusal topography the patient has naturally, and it is best if we can try to mimic this by using the stem technique. So what you do is with this tooth, you are going to apply directly before you do anything. You're going to make sure that you blow, you dry. You're going to apply your flowable composite. Then you're just going to insert your applicator tip, just like that. right? So you're going to apply your flowable composite directly here before you do anything. Make sure it's just dry and free of debris and everything. Then you apply your applicator tip. Then you cure it. You just cure it, and when it's dry and done, you just literally pull it. So that's going to be my stem. That's the negative imprint. So this was the stamp that I got. Then you're going to do your caries removal. I'm sorry, this might not be the clearest image, but you are going to do your cavity preparation as usual. How you're going to do it, making sure that there are no caries left behind, that everything is good. You do your beveling, and then you blow and you apply your, then you might want to irrigate and just blow. Then here I was applying my my agent, my phosphoric acid agent. Then here, then I bonded. Then I went straight to apply my flowable composite. I was using an A2 shade, so I was applying layer by layer. It's just the usual. But for the final layer, so you're applying your first layer, you cure probably your second layer, just, well, of course, it will depend on the depth of the cavity. But for the final bit, you're not going to cure. You're just going to leave it like that. You leave your flowable composite like that. Then what you're going to do is you're going to take a Teflon paper. You can use a Teflon paper, you can use even alternative wrapping plastic papers, the kitchen wrap, that one. Then you're going to just gently put it on top of the final increment, right? So you're just going to gently place it there. Then you're going to take a negative imprint. You're going to take your negative imprint, the stamp, and you're going to gently place on the Teflon. The excess is just going to smooth over the edges, but what you're aiming for, you want to just precisely just place it on top of the tooth. Once you've done that, then you cure, then hey presto, you have reproduced the original occlusal anatomy now that it's free of caries and it's just composite and it's delightful. Then you can go ahead and do your articulating paper. And for this case, I was actually amazed that there was a little minimum adjustments I had to make, because everything seems to be just good and it's just amazing. Just like that, you have re-established. So no more stresses of trying to go with your rugbies and trying to re-establish that textbook anatomy. Now you've just restored. The patient, when they feel it after you've polished and done everything, they're just going to feel that it's just their tooth, the original tooth. So they'll be shocked. Is there anything? Did you really put any feeling? Because it's just nice. And they can relate to that because they would hear that topography for the longest. So in essence, that's the stem technique. So we came from here right straight to here, which is good. Right, so of course, there are pros of using this. It's time efficient. You find that you really have cut your time immensely, and for the adjustments of those ridges and asking the patient to put the articulating paper, to chew on the articulating paper and then adjusting again. And if you just continue to adjust, you are obviously going to end up noticing that you are really compromising the anatomy you would have restored. But at the end of the day, you just want to make sure that the patient is comfortable, but now the time factor is being addressed. Number two, we have established accurate occlusal anatomy. Yes, it's accurate in the sense that this is the original anatomy of that particular patient. So we're not exactly the same in terms of our dental anatomy. So this is an issue of patient comfort and also just feeling good about your work at the end of the day. Then it is relatively economic. Maybe I might just put a closed quote on that, because it depends. Here you're just going to procure your Teflon paper or your shrink wrap, as I've said, but everything else you should have those in your clinic. And I must also add that for that stem, where before we do the cavity create, where we are just putting our stamp, there are alternatives you can use. You can use the gingival barrier, the one which is used for whitening procedures or other similar procedures. That gingival barrier can also work as an alternative material to your flowable composite. Then if you have flowable composite that is expired and sometimes you just feel like it's not economic to dispose, you can just use that expired to just make this stem, because this stem you're just anyway going to dispose it. So you can use expired composite, you can use your gingival barrier. So yes, it is relatively economic. Good. But of course, there are cons. There's also the disadvantages, because the procedures you are going to employ this stem technique on are quite limited. One, since we need an intact marginal ridge, right? So this technique can't be applied to cavitated teeth. And also, needless to say, we can't apply those to anterior teeth. Your class 3s or 5s, you can't. So that's why I've said from the beginning, and also according to Ramsey et al. 2015, the technique does not replace a good knowledge of dental anatomy, because if you're faced with a case where really you have to employ your good anatomy, then of course this is going to be a downside. So limited cases where you can really employ this, but for those cases, it's amazing. You can really produce amazing results. So your pits and fissures, your class 1s, or your class 2 restorations, you can just do everything else after you put the way you do your class 2 restorations, but on the occlusal, you can just employ the stem technique. Number 2, it is limited posterior restorations. Then number 3, it is technique sensitive. So of course they need to offer precise alignments on your stem, and that can also be the downside. So these are just the references I've used when I was researching on this novel technique. So yes, ladies and gentlemen, it was quite a short presentation, but I can open the floor if you have any questions regarding this. Thank you very much.
Thank you so much, Dr. Madede. A short and precise presentation. I have a question. What's the major challenge that you might face when doing the stem technique?
Okay, right. Good question. For when I did this for myself, the first challenge came here on the slide on the placement of the Teflon. If you've used the Teflon for whatever, you know that this is a very vulnerable piece of material. It easily falls, it easily bulges, and so you really need to have your steady hand so that you gently just place it. That was challenge number 1. Challenge number 2 was on the precise alignment. Guys, you have to really remember how you would have aligned. You must precisely align your stem towards your tooth surface. So if you misalign, you might end up you might end up altering the anatomy. So you just want to align as perfectly as possible. That's why this is a technique sensitive procedure. So if you align perfectly, then you stamp, then hey presto, you're going to really have a beautiful, beautiful result. Yes, thanks for the question.
No, thank you so much for the answer. Wow, also another question. You were discussing the use of mainly composite when doing the STEM techniques. Is it only limited to composite, or we can use other materials such as glass ionomers or zinc oxide usual?
Okay, excellent. I actually have heard that question when I first bumped into and discovered this. But unfortunately for the literature that's out there in the academic journals, they really were focusing on composite restorations. And I was trying to figure out why they were not employing this for the glass ionomer cements. It's still part of my study. I hope I will bump into, because I was wondering if you have probably your light curable flowable GIC. I just reckoned that probably you might employ this, but this is still part of my study. And really, I will come back to you when I've done really a comprehensive study on that. But for now, this has been developed and researched as they were using composite resin. I can also open the floor to anyone who might have the answer to Dr. Chitima's question on the use of GIC. But from what I've researched, they were really using the composite resin. Thank you.
Thank you. So we have opened the floor to any questions regarding the STEM technique. Message from Dr. Mungani. She said, nice presentation, Doc. Thank you so much.
Thank you. Thank you very much.
So no questions from the audience. So this is the end of our meeting. Thank you so much to Dr. Madede for your time, and also thank you so much to the listeners for also your time. We'll meet again in the next meeting. Thank you.
Thank you very much.